explain why SFMA exists. I won't do it any justice because they have a lot of great research backing it up and a lot of reason they've been developing it for years and years. But selective functional movement assessment, so that's what it is. It's a movement assessment, and just think about it from this standpoint. One thing they explain is that we have other healthcare people that we go to annually. Go to the dentist twice a year. Go to the eye doctor, once a year at least. You go to whoever else. You have these annual checkups just to pick up on if anything is abnormal. There's nothing like that exists with musculoskeletal system. Typically, anytime you get the musculoskeletal system assessed, is because you're in pain already or something is already going on. So the purpose of SFMA is really to be that movement assessment. So you can I like to think of it from the standpoint of, what if you didn't have that patient and you met discharged, but come in annually once a year, you just do a SFMA assessment on them, just to be able to identify any, mobility deficits or any altered motor control deficits. So that's really the purpose of it. It was developed with that thought process. At the class, they dropped a bunch of research, but one of the biggest things that I remember and stood out to me is that exercise was one of the. They took data from emergency room, and it was a significant amount of people that were there because of exercise. So whether it was an acute injury from exercise, whatever the case may be, and what they determined is that a lot of people, we as physical therapists, we tell them, hey, go out and exercise. The doctors say, hey, go out and exercise. However, we tell people to exercise, they really don't move well. They may have altered motor control. And anytime you have that combination of people going out and exercise that have impaired motor control, then that eventually is going to probably lead to an injury. So these are normal functioning people that, that look like nothing is wrong with them. And when we get to the rolling pattern, I kind of talk about my patient yesterday. You saw her. She looks fine, she walks fine, but she couldn't roll from her back to her stomach to her back. And there's significance of that. So just some of the principles of it. My throat is draining a little bit, guys, so forgive me for coughing a little bit. So principle. So they have three principles that they kind of base it on. First, move well, then move often. So pain-free movement does not mean no dysfunction. So you got a lot of people that have no pain at all, but they have dysfunctional movement. So essentially, adaptations become compensation. So I have a model in here somewhere that really explains it. So this is, I want to show you guys this if I can. Let me see if I can enlarge this. I may not be able to. Let me just break. If you guys want to, can you see this model here? Pain. So someone has pain. They have changes at multiple levels of the motor system, redistribution within muscles, so that may see them compensating, antalgic gait, something like that. Changes mechanical behavior. So for the short term, so that's more the compensation. Okay, so if they hurt their knee, they may start to, so the mechanical behavior changes. The short term, that's good because it protects the tissue and allows the tissue to heal. However, long term, if the adaptation never goes back, then it begins to become a long-term consequence, which is going to create dysfunctional movement. So on that model there, they call it high threshold strategy. So following an injury, your brain can continuously engage muscles to protect, as in co-contraction, even when an injury is healed. So you'll see people in this high threshold pattern. You see it a lot with lumbar spine. A lot of the muscles in not lumbar spine, but just spine in general. You got a lot of the superficial global muscles that are contracting and not the smaller stabilizing muscles.
Upper trap, huh? That upper trap.
Yeah, upper trap. You see it all the time. So, we talk about the difference between nociceptive pain, peripheral neuropathic pain, central pain. Don't want to go into that, but there are three models that or perspectives that this is really based off of. One of them is ultra motor control, like we just finished talking about. Another is the neurodevelopmental perspective. So people should be able to do just normal patterns, like our bodies. When we develop patterns of movement, not parts of a movement. So a lot of times as physical therapists, we could be trained to focus in on one part. So if the knee is hurting, we assess the knee. Now, we've learned to look at the joint above and below, but what about just having them do actual squat, or looking at different other patterns that they normally should be able to do. So that's where the rolling comes from, because they've integrated how do you begin to assess some of the normal neurodevelopmental patterns. And of course, regional interdependence. They have a pretty cool definition. I can't remember how he says it exactly, but essentially, our bodies are developed in a way where there's a series of stable joints followed by mobile joints. So if you look at it, you think about it, and what they consider stable mobile joints, so every single joint moves in all three planes, but some joints move in all three planes very well, like the ankle joint or the hip joint. However, the other joints, they don't move in all three planes. They have more of a dominant movement, so think about the ankle joint, mobile joint, so it kind of moves pretty well, but then the knee joint is a stable joint, mobile joint, the hip, then lumbar spine is a stable joint, thoracic spine, mobile joint, so on and so forth. Even going out to the shoulder, mobile joint, stable joint, mobile joint. So that's just kind of how our body is developed. However, when you see dysfunction, they have some pretty cool photos. You'll see the very opposite. So you think about a lot of your back patients come in, hips are stiff, thoracic spine stiff, and a lot of these changes in movement really create some of the dysfunction. So the thing about their system, SFMA, they have SFMA, they have FMS, and they have Y balance, and each one of those systems, they kind of have a specific purpose. One thing they encourage us is if you can't provoke pain with the SFMA, then go to the FMS, because FMS is just that, it's a higher level. It's less movements, but it's just that next tier of challenge where it probably would provoke some pain. But just to go, so any questions so far? All right, so to go into SFMA, so Joe mentioned it earlier. We scored on, 4 different, so the score system is 4 tiers. So someone can either be dysfunctional, non-painful, dysfunctional, painful, functional, non-painful, and functional, painful. So those 4 things. Typically what you're looking for are the dysfunctional, non-painful. So they have I'm gonna show you this, I just threw one away. But they have a system, and it is red light, green light, yellow light. So green light means go, of course, and yellow light is slow down, and red light is stop. Don't even look at it. So this, when I'm actually getting someone to go through the movements here, these are the things that it kind of talks about the priority of movement. So you have several movements. So this is the SFMA top tier. Each one of these have breakouts where you can kind of determine exactly where the dysfunction is coming from. But dysfunctional non-painful, that's green light. If you find any dysfunctional non-painful, that's what you want to go for first. Dysfunctional painful, functional painful, and functional non-painful. So if someone has a functional non-painful movement, there's no sense in looking at it at all, because you're saying that more than likely they don't have any ultramotor control, they don't have any mobility deficits, they don't have any pain at all. So it's no sense in looking at that.
That's where you want them to be.
That's where you want them to be, exactly.
Mm-hmm.
One important thing to note is that, they talk about the difference between dysfunction and pain. But anytime that I'm giving someone a clinical diagnosis based on what I find, it's either going to be a mobility deficit or a stability motor control deficit. So for instance, if I'm looking at someone's thoracic spine and I realize that it's not actively, they can't get it there, but passively I can get them there, then I would consider they may have a left thoracic thoracic stability motor control deficit. So they just look at it in those two functions. Either have ultra motor control or a mobility deficit. But I really want to go through these. So anybody want to volunteer and be my patient? Okay. All right. So let me. I'm gonna just walk through these with you guys. Would you mind taking your shoes off?
Yeah.
So one thing, always take your shoes off because that way you can standardize things. All right. So Joe, would you mind? Let's come right here just so the camera can get us. All right. So would you mind having your feet together? And I want you to. So you can stand up tall, just look down. So keep your mouth closed and then just bring your chin down to your chest. So every single movement, you're looking for certain characteristics of it. So with Joe, move your head, Joe, if you mind. So you're looking for, with this one, can they bring their chin down to their chest? If they don't have at least one of the characteristics you're looking for, then you can go ahead and call it dysfunctional. So that's where you go down. Okay, so so you're looking for uniformity of spine. You're looking for, can they bring their chin to the chest? And with these, I think that those are only two with this particular movement. So the other one is you're looking all the way up to the ceiling. So they should be able to get 80 degrees below horizontal. Well, if you imagine 90 degrees, they should be at least 80 degrees. So 10 degrees above, less than horizontal, above horizontal. All right, perfect. Face that way for me if you don't mind. To the right.
To the right.
All right, so I'll find someone's clavicle when I just come to that mid clavicle and I ask them to rotate their head to the left. So you're looking for their nose or their chin line to go beyond where my finger is. This imaginary line that goes up from their mid clavicle. Go to the right for me. All right, perfect. So that's cervical spine. So the next motion I'm gonna get you to do is take your left hand and reach to touch your opposite shoulder blade. So I'm looking for winging here. I'm looking to see if they can even touch it. All right, so go to the opposite. All right, perfect. You can bring it down. Now I would say
Here, what's normal?
With this one.
Range?
So normal is they'll be able to at least touch the tip inferior angle of the scapula, and there's no winging.
No winging.
And that and it's a pretty smooth movement. So if they're doing
There's no winging?
no winging.
Yeah, no winging. I generally
How's that
see
possible?
winging. Yeah.
Yep, that so I would say this is that would be, is that any pain?
No.
Yep, so that would be dysfunctional unpainful. Yeah, you shouldn't have any winging. I mean, of course it's gonna come out some, but it shouldn't be excessive winging at all. But also the movement, so if you look at mine, this is, from my left side is functional, non-painful.
Okay.
But watch when I move the, you see the effort it takes to get my right one back there? So this is pretty smooth.
It's just smooth movement. Wow.
So you gotta pick up on those small nuances. So one thing they say is that if something is weird about it, just call it dysfunctional. Because it's better for you to call it dysfunctional than say it's functional and you miss something. So you might as well just call it dysfunctional and then you can go back and look at it.
And that's how you put in your notes too? You use those terms?
That's the tricky thing. I'm trying to figure that out because nobody else will know what I'm talking about. So I'm trying to.
Just put SFMA at the end.
Yeah, that's what I've been doing.
D.
Yeah. So I haven't put SFMA top tier and I put cervical whatever. It's a lot.
With the SFMA though, people should know.
Yeah.
What you're talking about.
It is a lot to type too though. So I've been trying to figure out. I'm still working on how do I want to.
Because you're not. Yeah, I mean, you're not, in this case, you're not actually measuring range of motion, right?
Well, I mean, you are, but it's not, it's gross. So you knowing that this is 45. So they should be able to get at least beyond, they should be able to get at least 80 degrees is what they say. So, and they're saying that based on the fact that if you go mid-clavicular line, that should be 80 degrees if they can pass that. So I am, but I'm not.
Right.
If I really need to know, I'll pull out the goniometer. But I'll give you some more examples later.
Usually I'll just write like 70%.
Oh, you would?
And like I don't measure, because there's so many factors that go into it.
Yeah. I mean, if I'm trying to
measure degrees, unless it's like the shoulder. When it comes to cervical, I don't know.
Oh, well, cervical. Sometimes a lot of times I use the goniometer over and go.
Yeah.
I mean,
but like you just eyeball it.
You could, yeah, you could, absolutely.
Right.
Sometimes I use an inclinometer with it. But with this, yeah, they didn't teach us to actually put a number to it. We didn't pull out tools at all, which you definitely could. So that's pattern one. Pattern two is this. So could you take your hand over your head and touch? And so you had a little training on this?
A little bit, not formal training, it's like
Okay.
the last place, like where I was working, they trained a little bit on it, but not, I mean, like, I don't know these
Okay.
tests that you're doing right now, I've never done those.
So with what Joe just did, Joe might actually do the right hand again. So you see how her cervical spine flexes a little bit? Oh yeah, the ponytail could be in the way too. Okay, perfect. Alright, do it on the left side. Yeah. Okay. Yes, I mean, I think that looks pretty good. So that's this upper extremity pattern. Now I'm gonna ask you to bring your feet together, and I want you
Face
to,
this way?
yeah, you keep facing that way. I want you to look down at your toes and reach down and touch your toes. So again, you're looking for, so the sacral angle, I can't really remember that, but the sacral angle should be at a certain, I think, 70 degrees maybe. Uniform spine, they should be able to at least touch your toes. You should see a posterior weight shift. When they go down, you should see a posterior weight shift. So if someone is touching their hands, we tell them, don't be overachiever, I'm just kidding, but we just tell them, touch their toes because it can cause them to shift forward. Alright, so the next one is both hands up and eyes up. You gotta go back as
Eyes
far as you
and
can.
neck, or just?
Yeah, you're looking at your hands, and then you lean back as far as you're comfortable going. Alright, so you're looking for ASIS to be in front of the toes. You're looking for the scapula to clear the heel. So it's just certain things you're looking for, everyone. Uniform spine, so on and so forth. Bring your feet back together for me. Yeah, so feet should remain together the whole time. Now, Joe, I want you to rotate your body. Keep your feet together and rotate everything else to your left. Okay? And then go to the right. So what you're really looking for is to be able to see her opposite shoulder when you're standing beside. So it's quite a bit of rotation, but it should be 50 degrees from the thoracic spine and from the hips as well. All right, and
So more than that?
oh yeah, significant more than that. I mean,
So
they,
you're
Like
limited?
my mid back is super, he worked on it, super locked up, like that's
Yeah.
not good.
they should be able to get like living. When you think about the person standing beside you, should be able to see your opposite
Like it should be like
opposite
a T.
shoulder. So when I get ready to break this down, I'm gonna assess the mobility of the thoracic spine, hip, internal external rotation, tibia, internal external rotation. And I'm like literally hitting every single joint.
Do you
Next
like
one.
squat, or is that more like FMS?
No, that's the last one, the squat.
Yeah.
So then single leg stance. Could you stand on just one leg, 10 seconds? So you get a 10-second hold there. You're looking for any type of movement, so you can switch sides. Alright, good. So you do both sides, and then you ask them to, alright, go back to the right side, but start with your eyes closed when you feel comfortable. Close your eyes. Yeah, but of course you
Start with my eyes closed?
Well, I'm sorry. Start with the eyes open when you feel comfortable. Close your eyes, and then you do the same thing on both sides. 10-second hold. Here's the squat. So feet together, arms out in front of you. Then I want you to squat down as far as you can go. So if you're looking for to drop below parallel hip. Now, if you can do that, bring your, close your hands and bring your fist down to the ground. But from this position, so you start here,
That's
and when you get there, then bring your fist down to the ground. Okay.
That's really hard.
Yeah. So typically, this is your counterbalance, because I can go down, but when I come here, I fall backwards because I lose that counterbalance. So I don't have the control. But that's the top tier. We consider it top tier.
Okay.
The purpose of the top tier is to determine what we're gonna look at first. So we're grading these, functional, non-painful, X, Y, and Z. So when I'm gonna start with all of my dysfunctional, non-painful. So I'm gonna just show you. It's a lot.
I wonder about your dorsiflexion, huh?
Hmm.
I'm already trying to assess.
Oh,
Without the training, but
dorsiflexion.
yeah, I'm wondering why? Because you posteriorly shifted if you're losing your balance backwards, huh?
Well, my dorsiflexion in the class was pretty good. I think it's more. I don't know why I fall backwards. I mean, because I can get down there,
Right.
but I don't know. I just don't have control. But where is it coming from? I couldn't tell.
It's like,
You're not shifted anteriorly enough.
and then you bring your arms back.
Bring your arms at least down to your.
Yeah, see, I feel like that's not, like I just don't have the core strength.
So let me break out. So let's do the cervical spine breakout since it's pretty straightforward. So I saw Joe. I say, okay, Joe. She came in. She came in with let's say she came in with neck pain, but cervical flexion was dysfunctional, non-painful. So we're gonna look at that first. So one of the logics is you take away you change the position. So she goes from standing up to a more stable surface. And I actually do the same exact movement. So Joe, I want you to bring your chin to your chest. Okay? So Joe, she still can't do it. So what I'm gonna do, because surprisingly some people can do it just from standing up, they can't do it. So they may have more posture, a little more control. So you just relax. Let me see if I can. Okay, so I still can't do it. So what I'm gonna do, I gotta kind of determine where it's coming from. So you just relax you. I'm gonna rotate you. Now from here, I just want you to tuck your chin. All right. So she should get 20 degrees. That's not 20 degrees. So I'm looking at the OA joint at that point. Let's go opposite way. Tuck your chin. Yeah. So barely get any movement there. So I would say her upper cervical and OA joint is limited. And it could be both. It could be upper cervical and lower cervical. Alright, and then we're looking at rotation. So again, rotate to your left as far as you can. Now he or she goes a lot further. She actually can do the movement. Go to the right part again. Yep, she actually goes further on the right side. So the difference. So she couldn't do it standing up, but you can do it laying down. So I would consider that postural stability, more control. Well, let's say
Not mobility.
it's not
She
mobility.
has mobility.
She has it. But if she didn't have it, the way I would look at that is take her to full flexion and say, Joe, go ahead and touch your left. Okay, so now I'm looking at the AA joint. Touch your right.
You're locking everything else up.
And just determining, okay, the upper cervical is more lower cervical. Extension would be, go ahead and slide back toward me, Joe. All the way to the point where I can support your head. Bring your shoulder back a little more. Going towards me, towards the edge.
Show it towards the edge.
Mm-hmm. I see you fully relax. I'm gonna just let your head. Okay. The only thing you're looking for on this one is 80 degrees. So if you looked at straight down 90 degrees, you should be at least about.
She's almost there.
80.
She's almost to 90.
Yeah, she's
Yeah.
there for sure. Any pain with that?
It's not.
Yeah, but here's the other thing you're looking
It's
for.
not painful.
It's
No.
not painful. You're looking for is the spine is a uniform curve or is she hinging at a certain point?
No, it's definitely lower cervical.
Yeah, so she's hinging at a lower cervical. So that's a little. You felt something there, huh?
Yeah, I mean, my like C1, C2 is always just like it always.
Oh, yeah. So for Joe, I would start probably looking at trying to correct some OA and really OA flexion and probably lower cervical as well. All right, so.
Not for like the hip.
Hmm?
It's very stupid at the hip.
All right, so let's say for instance, if we had if flexion was limited. So this one is pretty cool. So go this way for me.
This way?
But I want you to sit, so going long sitting. So if I had someone to say, do multi-segmental flexion, they couldn't touch their toes, I'll actually do it from this position. So again, I just changed stability requirements. So you could do it, you were able to do it anyway though. Let's say she couldn't do it. I would actually, so let's say you're there. Okay man, would you mind laying down for me? Alright, so now you're kind of breaking down a bunch of different things. Bring your legs in together. Well, you can keep your legs straight, just bring them closer. So I want you to keep your knees up. I want you to actually bring your feet up like so and keep your toes pointed up to the ceiling. Keep this leg in contact with the table if you can. I want you to slowly lift the right leg up, keeping the knee straight. Go up as far as you can. She's looking for it to get to 70 degrees. So I think she gets to about 70. Let's go on the opposite side. Yeah, she gets to 70 for sure. Let's say if she couldn't get to 70, I would ask her to do this. So I want you to hold both hands up in the air towards the ceiling. You can cross your arms over. Now, I want you to brace against me, okay? But you could do it at the arm, but you want her to push against you. So go ahead and push against me. Now, same thing. I want you to bring this leg up slowly.
Trying some core stabilization.
Yep, and then we'll do it on this side. So what their logic is, someone is pushing is gonna rock the pelvis and posterior pelvic tilt. So they may not have been able to get up because they were anterior tilted a little bit, so it was blocking them, it was blocking their hip from fully coming up in flexion. So if they could come up higher with that, they may have a pelvic stability motor control, pelvic orientation stability motor control problem. That's one thing I found on Andrew when I was doing that with him. Let's say if all of this was I'm still looking for something, I would go passively. And I would say, okay, passively, can I get it to the point? If it was still to a place where I couldn't get it, I would determine it's probably the posterior chain, which is kind of too tight. But still, we gotta break it out more. So bring your knees for me.
But you're just looking for 70, right? 70 degrees?
70 degrees on that. On straight leg raise. But when we do hip flexion, look for 120. So 120 without rocking your sacrum, without rocking off with your sacrum. So I want you to reach behind your legs and then bring both knees towards your chest. So you see how our sacrum is kind of at that angle? So I would get here. Now our sacrum is flat.
Oh, keep my sacrum flat.
Mm-hmm. Because at that point, you're starting to rock at the pelvis. It's no longer just hip motion. So when you keep the sacrum flat, they should be at 120 degrees
Wouldn't it?
of hip
Wouldn't
flexion.
if you left one leg straight, wouldn't that do it? Lock the
It
pelvis
would.
into place?
So I want to see both first, and then I will ask you to bring this one down.
Okay.
So you can keep your knee bent up, and then I'll assess. And Joe, you're pretty tight right there. So you're really not going. So your hip flexion is a little bit. And I mean, you can do your kind of assessment, internal, external rotation. I would do on both sides. So that's a finding right there of mobility deficit potentially. So that's more the flexion. If I'm looking at internal, external rotation, it's because they had dysfunctional rotation. So let's say, for instance, if you did, go ahead and sit up on the edge. Well, let's go this way. So I'm gonna ask Joe. So bring your hands right on you. So Megan, I know we're kind of getting outside of your realm.
No, this is good. This is cool.
Bring your hands right on your hip, and I want you to, with that leg, take your foot out as far as you can. So you're looking to see if she does this. So that's clearly more than 30 degrees. So if you just look 30 degrees of internal rotation, yep, you got that. Now I want you to go that way. So that may be a little limited. So you're looking for 40 degrees. And this one I'll pull out my goni to see, okay, is that 40 or not? So if Joe was limited here, I would look and see, okay, passively, can she get it?
You're just looking for 30?
I'm looking for 40 on external rotation.
40.
And 30 with internal.
Maybe it says it's the same way, like for I but we're looking for 60.
Oh, really? For what? External?
Oh,
Oh, really?
Yeah.
Crazy how they
Yeah.
It's like,
different logic.
yeah.
60
But
is.
you assess it the same way in sitting?
Mhm.
I haven't had 60. I don't know that
60
I've
is better.
ever had 60 degrees with anybody. I like to assess it in supine.
So not really, no, I don't think it too often.
Or for internal.
They have to have a lot of
Internal, I will.
Okay.
Oh, so you just bring up a good point. If someone has a lot of internal,
But it's also not, it's passive. So we're like passively.
it is passive.
Passive, yeah. And then they use manual muscle tests in that position.
So they would say, or they tell us to do the Craig's test because we want to see if they have any type of femoral anteversion going on. So yeah, prone. So after I assess that, okay, I see that maybe external rotation is limited. To be honest, I would get you in a chair as well and check your internal rotation, your external rotation of your tibia, internal rotation of your tibia, on both. That way I can look
In a
at.
chair with her foot on the ground is what you're saying?
Yep. So just chair, foot flat, knee straight. So that's tibial, external rotation, and then you see I'm compensating quite a bit to get into internal rotation with the tibia. Well, you're looking for, I think it's 20 degrees here and maybe 30, 40 degrees here. Can't remember.
Not a whole lot.
Yeah, it's not a lot. But those things essentially, if they can't get it in the position that you show them, then you'll go and you put them in a, get them on the mat, and you're gonna check it passively. So, well, let's do this. Go to your stomach, because you can't do the stability. So I want you to bring. Well, let's do this first. Go ahead and bend this knee. All right, I want you to bring your leg down towards. So I'm just stabilizing that pelvis. Bring this leg down towards this leg.
Here?
All right, come back up. And again, you're looking for the same 30 or 40 degrees. So that's clearly 30. I would definitely say that may be short of 40 because I feel you compensating a little bit. So I stabilize you passively. Okay, so that's still pretty tight. However, in fact, before I do it passively, I would ask you to reach on the side of the table. And let's get this back up. So put your arm underneath of the table, sorry. And I want you to pull up. So pull your arms up into the table. Yeah, so you're gonna reach on the side of the table, you're gonna pull the table up.
Like this?
Yeah, well, I know this thing kinda throws you off a little bit, but as best you can right there. So you pull up and then try to go down. So no change with it, so that wouldn't be a pelvic orientation problem. Then I'll do it passively. So you wanna look actively, then you wanna get them to try to orient their pelvis differently by contracting. And he said, you know, that was the best way they could think of to get someone to do it. He said, hopefully somebody will develop a different way to try to get that contraction for the pelvis. But you're trying to determine if it is a pelvic orientation problem or just so I'm trying to determine, is it also motor control problem, a pelvic orientation problem, or a mobility problem with those? What I'm going through are the breakouts, but I'm really kind of piecing them together because you could go through all of them at one time, but you don't want to have the patient up and down. So I got to get comfortable enough and familiar with it enough to know how I can pull from here and there. And then it's a matter of remembering all of those things. I try to jot it down, but it's a lot though. Another thing I think will be relevant to you guys is, which I was surprised that he said this, but on the vestibular, let me get 2 Arix mats. But he refers out if this is abnormal. And it may be the fact that
An Arix.
So he recommends doing it with 2 Arix. But it may be the fact that he focuses on, he's an ortho PT and not a vestibular PT. So he'll just refer out to a vestibular PT. So if this was dysfunctional, you saw somebody that just couldn't hold it, the way you break that out is, so another thing that's important about this, ankle mobility, they said that someone that this is dysfunctional with, it may not be a proprioceptive problem. A lot of times things that we normally call proprioception problems are mobility problems. So that's why you wanna, like in this breakout, you wanna look at the ankle dorsiflexion and just ankle inversion, make sure they have good mobility. If they do have good mobility, then you can say it's probably more of a proprioceptive problem. Because a lot of times people just don't have good ankle mobility. But anybody else want to try? Joe, you want to still go?
Yeah, that's fine.
Okay. Alright, so go ahead. I'm gonna hold this so you can stand on it.
Was both feet?
Both feet, yep. So you start both feet, and you're gonna do 20 seconds. 20 seconds, and let's say you're fine. Let's say close your eyes. You go 20 seconds. Let's say you put solid on there. So now I'm gonna get you to go eyes open.
Okay.
And you're gonna turn your head. You're gonna go up and down with your head at my tempo. You can do it maybe a few times. Now left and right. To the left and right.
Dizzying.
Now I want you to side bend your head back and forth. Alright, good. So now I need you to do an eyes closed, up and down. Alright, left and right.
I'm sorry. It's like,
I mean, you're pretty steady.
wait, hold on. I'm like, where's the snap?
And then side bend. Joe barely moved. So that's normal. I mean, if you have someone, if they fall off or they just like, they can't find themselves in space, then with their eyes closed and head turned, then that's a good time to refer them out. So I like this as a test, just, you know, for my patients that's having dizziness problems, I can just do this.
Right.
I did this on a lady the other day that was in a car accident, and she, it was abnormal for her. So I told her we're gonna look at it one more time. She comes back, but if it's still that bad, we're gonna send her out. I'm gonna show you guys a rolling real quick, and it's 1:48, so I don't know what we're supposed to transition to. I'm going to show you the rolling. All right, Joe. Joe, I had you do this earlier, didn't I?
Mm-hmm.
Okay, so if you're assessing rolling, Joe, lay on your back.
Put my arms up.
Excuse me. Go to your back.
Way back.
So the first time I wouldn't coach them in anything, I just kind of assess them. So the 8 movements you want to do. So both arms gonna be over your head. All right, so Joe, everything from your waist down, you can't use it at all. Let's just act like you're paralyzed. Can't use it. Let your right arm point towards the ceiling. So you're gonna roll to your left. Now you can't lift your head up and follow your.
I can or I can't?
You can't. You
You're
can't.
not allowed to.
But I want you to roll all the way up to your stomach.
There you go.
Alright, and you can, so from here,
No, easy.
now she did cheat on that, I don't know if you guys
I
caught
saw
that.
that too. I saw that.
Alright, so from here, take your right leg and you're gonna lift it up and over, yep, just perfect. It's usually, I mean, the legs are heavier, so it's easier, usually easier for me to do the legs. Alright, let's go with the,
So it's like this.
mhm.
Yeah, see, I don't know if I can do that. That's like really hard.
I don't know why I mix arm and leg, but we'll go ahead and go. So, let's do left leg. Alright, perfect.
Yeah, the leg is so much easier.
And now we're gonna go leg over, so
Leg.
left leg up, well, either one, bend your knee, and arm still overhead, everything from your waist up, you can't use it, allow your leg to come over, and roll yourself over. But obviously you wanna do arm going to extension, so left arm up, and you can lift your head, yeah, just like that. But you're assessing every movement, so it's 8 different movements you're gonna assess. You would notice that some people can't do it. Now, here's what they say, if someone can't do this, they have more of a global motor control issue versus a local motor control issue. What I mean by that, if I was looking at thoracic spine rotation and they couldn't get to 50 degrees, well, let's say they got to 30 degrees, but passively I can take them to 50 degrees, they would have a thoracic motor, stability motor control deficit. So that's more of a local altered motor control. If they can't do these global patterns, they have more of a global motor control. That's one thing I found with my patient that was she was in a vehicle accident over a year ago, and I had to do this, she could not roll. Both of them, two patients, one yesterday, the other day before, a motor vehicle accident, they could not roll. Like literally, they could not roll without compensation.
Well, I mean, even Joe did a little bit, but I don't, is that normal? I mean,
What do you mean?
well, she had a little bit of compensation with her hips when she was just supposed to use her arms from supine to prone. But I feel like most people would have that. Is that?
So a lot of people probably
unusual?
would, but you should be able to do it without compensation. And if you can't, then you want to train it. So with Joe, I would start training that on how she can do it. But these two individuals, they couldn't get over it all. They got stuck. They couldn't even go halfway.
Can I try it real quick? Like, I'm curious now, like that.
And then some of you would notice that
That looks tricky. Doesn't that
It's
look
a little-
tricky?
a little harder than others. Rolling one way is harder than the other way. Make sure I'm catching this on camera. No, I'm not really getting it.
So I lift this up.
Yep, so everything below your waist down is paralyzed. You can lift your head.
Okay.
So lift your head and
Yeah, I feel like.
see how you're pushing through his leg.
Yeah, I feel that. I don't know that I can do it without.
So let your right arm rest down.
Okay. And then.
So, and this is a big thing to note as well. Cause I would only go, really, you only should go through this if someone doesn't have any mobility deficits. So if they have a thoracic spine deficit, like, Joe is probably gonna compensate because her thoracic spine is a little more limited.
Like, I can do it if I push a little bit through my legs.
So that may be why someone compensates, because they don't have full mobility to do some of these movements.
That's interesting, and I didn't think I could do it.
Yeah, but I mean, that's it, guys. I mean, it's a lot to it, a lot more to it than that, but, I don't really think. So, did I share anything that made you guys maybe integrate in practice? What about you, Megan? I know that, so you're doing mostly neck stuff, right? That would, well, I know you're doing a lot of hand and wrist, but.
Yeah, and I like the way that you explained it, like the stability versus mobility, right?
Yeah.
And those joints and looking at it in that terms, and then, okay, so if it is at certain areas, looking at, are they dealing with the stability of it that's impacting it, or the mobility of it, and kind of narrowing down the treatment to them? Because I was gonna ask, how do you then take this and implement it into treatment? What does that look like for you guys, or for somebody with upper extremity? What would that look like for their treatment?
Two different
plan?
things. The joint depends on the joint, so they're not both. One is a mobility joint, and then the other is a stability joint. So
So like shoulder mobility,
Mobility.
elbow stability,
Right.
wrist mobility,
So
digits.
More stability.
Stability, yeah.
Hinge joints, yeah.
Okay.
But so for instance, the guy earlier, I'm sitting for a shoulder,
Mhm.
thoracic spine, I assessed his thoracic spine. He could not get, let me say actively, he could only get to a certain amount. I checked him passively, he still only got to that certain place. So he had a mobility deficit. So I came and I did joint mobilizations and I reassessed it. But in your case, like if you notice, if you were checking them actively, you notice that, their range of motion was limited. I mean, it's just checking passive motion afterwards, just to determine if they have the motion. Because if they have the motion, they should be able to access it with their muscles. But if they can't, then they have some type of altered motor control that's preventing them from accessing it. Stability motor control.
Okay.
And then I would probably change, as they say, change the stability requirement, because sometimes if you put them on I think you would really appreciate their interventions, because it's based off a matrix. So you can do one by one, 1 by 2, 1 by 3, so on and so forth. But part of it is the position that they're in. So let's say, for instance, I can't remember the other. Oh, I have it right here. The other principles. Well, a part of it is position that they're in. So the first position you start off with is actually in prone. Excuse me. Supine, I mean. Let me see if they have. So okay, here's the matrix guideline. So 4 positions. So supported, suspended, stacked, and standing. So these are the positions of the spine. And then feedback, demonstrate capacity with feedback and capacity. So let's say a 1 by 1 matrix would be, it could be prone or supine, because it's just the spine is supported. So for me, my spine is supported. Spine is supported from here. Suspended would be, now my spine is suspended. Stacked, now my spine is stacked. And then standing. So you want to progress the exercises from that standpoint. And feedback, you give them feedback, like if Joe was doing a rolling, I said, hey Joe, okay, you want to be careful not to push through your leg. That's feedback. So that's a one-on-one type of exercise. And it progresses like that. Demonstrate, I'll take that back. Feedback is me just telling her. Demonstrate is, I say, okay Joe, could you show me rolling? Then she's demonstrating it. And then the other 2, I don't know, I hadn't made to that yet. So I'm still going through the content.
Okay. So with these 4 phases, do you go through each position? Like you're in supported, so you want to progress through these 4 before you go to suspended?
I think it depends on where they are. I don't know if it's a continuum like that, but you definitely don't want to skip to, so do you go through each one of the 4 with the position, with each position?
If they're supported, you want to go through feedback, demonstrate capacity with feedback and capacity before you move on to suspended? or,
No, I
No,
don't think so.
no.
I don't think so.
cause you wanna, I mean, sometimes you can use these different positions concurrently, like in the same treatment session, not
Yeah,
concurrently
exactly.
in the same exercise.
And if you guys ever wanna access this, here's some great examples of, they have a bunch of different exercises in here that tell you this is a 1-to-1, 1-to-2, 2-to-1, 2-to-2. You know, so just different things that you can do if you're trying to, develop motor control. This criteria here, this is if someone has laxity, you know, if you got a kid that just Marfan's just totally can move too much, you do that criteria. I think is if they have over 7 or something like that. If over 5, then they're positive for hypermobility. So when someone has hypermobility, it's gonna be a little harder to get them, you know, working and improving their motor control. But those are the places you don't want to be doing mobilization on. You just want to really help them try to gain control and just have too much mobility. Which I've never heard of that before. No. But a couple things that may be important. I remember them telling us is mobility before thoracic mobility before shoulder mobility. So if someone has if you're trying to improve their shoulder mobility and you haven't assessed their thoracic spine, you could be making their shoulder more hypermobile because they need good thoracic mobility. Because if they don't, it's gonna compensate. It's gonna compensate through the shoulder.
We spoke a little bit about that last week.
Yeah, oh, did you? Okay. Yeah, so it was thoracic mobility before shoulder mobility, and always always mobility before stability. So one thing that I did in practice, which I'm gonna change, is sometimes I would work on if someone had a very, very stiff lumbar spine. I realized that in times past I spent a lot of time trying to improve their lumbar mobility when I hadn't really improved their thoracic mobility enough. When you think about it, the lumbar spine is supposed to be more stable than the thoracic. So
The lumbar is supposed to be more stable than.
Yeah, that's not a place you wanna pull a lot of mobility from.
yeah, not
Thoracic.
at all. The thoracic
The lumbar spine, you don't wanna pull a lot of mobility from the lumbar spine.
But generally people do, and that's why there's so much lumbar
yeah,
dysfunction.
and they should.
Yeah,
Yeah,
you see a lot of the set joint dysfunction. in the
right,
lumbar
in the
spine.
lumbar spine, because that's where people generally
Herniation.
are more mobile, cause
It's supposed to be, the anatomy of those vertebrae, it's designed to be compressive.
cause those, the set joints.
Right, so if you start pulling movement from there,
Cause a problem.
Yeah,
I don't ever mobilize.
I actually don't do it too often too, cause it's like the thoracic spine's always so stiff
Mm-hmm.
with anybody who has any kind of lumbar spine issues, so.
And I do mobilize the lumbar spine quite a bit, but I think I wasn't focusing enough on do they have enough thoracic mobility to do it. I mean, because literally, some people, I just felt like they couldn't move at all. So for you, Joe, when you're treating the spine, lumbar spine, are you just doing more stabilization stuff and more breathing things, and how you approaching it?
For lumbar, like if they
Oh
have,
yeah, lumbar spine.
like if they have like a lumbar.
Let's just say they have lumbar pain, just in general. Let's just say, for instance, if it's a
Usually with like lumbar pain, I'll do like more reversal, so like take them out of the lordosis.
mhm.
Cause a lot of times I find that there's too much lordosis in the lumbar spine.
Okay.
So you're looking at the pelvic, that anterior pelvic tilt.
At the
Trying
pelvis,
to-
yeah.
Yeah, trying to reverse that, so what you mean by reversal?
No, so like putting them into like a tucked,
Yeah.
so like a posterior pelvic tilt, and then like reverse the curve down here.
Like soft tissue stuff while in that position, or
Yeah. So soft tissue stuff, or I just won't even really touch it, I'll just like go straight to the hip.
just try to improve hip mobility, thoracic. Yeah, I mean, which makes sense, makes a lot of sense.
Do like soft tissue and like QL.
What this has helped me do is think more globally.
Or
Okay.
lat inhibition stuff, things like that.
Yeah.
Like, I'll do like a lot of like reciprocal inhibition when it comes to like lower back pain.
So just kind of getting them to
Like what?
contract
Yeah,
forward.
like TA.
Yeah.
Contraction.
What do you do for lat inhibition? What do you do there? What kind of?
So like that position
Mhm.
is a good example of one. The breath
Did
work
you,
that I do.
you had the arms stretched out? Was that more of like a prayer pose? I was looking at your legs, I wasn't really looking at your arms. Were you more like this?
Yeah, so you could do, that's a good position to do like soft tissue work. Or like you could just do like bring the elbows under and then push. So if you're trying to get into like more inhibition technique, push the elbows down.
Down like into the knees or
So
down
as
into
I
the mat?
exhale, now I'm pushing down into the table, and I really feel like transverse abdominis.
Mm-hmm. Oh, so you're trying to get
Push
contraction
the ribs
here,
back. Yeah.
so you can relax here. I like that, cause I have some people that just like, I cannot get their spine.
It's usually a problem of shutting down.
You got
they
too,
can't
you got
shut
that
it
high
down.
threshold strategy, just too much contracting.
Right, so like they're so forward in their posture that like as their weight, especially around here, everyone's like chubby around here. They like come forward, right? Cause they're like big. The weight comes forward and they just immediately like, see, like as I bring my weight, like that's not me doing this, right? That's me shifting my weight forward and like I can just
And
feel,
your body just oriented itself,
yeah.
putting you in that pelvic
Cause
tilt.
I'm coming back
Yeah.
as that weight comes forward.
Yeah.
And then you just, like anytime you're in that position, you just get paraspinal like irritation, sexual irritation. Yeah. Hanging, I'll do a lot of hanging for distraction. I don't trust that bar. That one's a
If
little
you got it up
sketchy.
good, it'll work.
I'm like,
Yeah.
sometimes I'll like hang myself and I'm like, ooh, I don't know about that. But like just like hanging with the knees forward, where you can get the like tailbone tucked under, is very helpful. Just like some distraction. The lumbar side is annoying.
Yeah, there's a lot going on with it for sure. You know, one thing that I think was like a quick assessment that I like that I took this weekend or last week was assessing hip extension, and really, because one thing they say is that you should get 90. Would you mind going flat? Show you that. This might be that. So they should be able to bring their toes beyond their heel on the opposite side, where you want to have your. You might put my hand in front of your hand. So you want to have your hand in front of their ASIS, so it shouldn't dump into my hand. So go ahead and lift your left leg.
With like straight leg?
Straight leg. Like so, Naomi can bring it down. Go again. Alright, do it one more time. Yeah, so she should be able to go up without that ASIS tilting forward. You tilt forward a little bit. But then some people, as I started watching it, you can see some people go into lumbar extension. It looks like you're doing a little lumbar extension before you get to that point.
With the right?
Yep, you are. You're definitely going to lumbar extension. So that's a nice little assessment.
So that would be more motor control then, or well, actually, no, we haven't determined that, if that's mobility or motor control.
I usually do that. So I'll do a favor first, and I'll do a modified Thomas test. And if both of those are positive, then I won't even look at that because I know it's positive. But if they're negative, then I'll look at that. Yeah. Good talk.
Yeah. Helpful.
As I learn more, I'll share more.
Ma'am?
Do you need your phone?
Oh, no.
No, it's
You guys done?
Yep.